It's the internists and cardiologists who see these patients on a regular basis, and the introduction of this concept is a very slow process. When we first started appendage closure therapy 7, 8 years ago, it was a very small trickle-down effect. You'd occasionally get a patient referred to you primarily who was a poor candidate for anticoagulation. But as you start doing more and more cases, it becomes a waterfall effect. And patients talk to other patients, patients talk to the referring doctor. When we started the education process here in Santa Monica, we really started with a large-scale educational effort such as Grand Round. So that was one of our first presentations so that you can introduce it in an objective academic fashion to the medical community. So I presented at a Grand Rounds our initial research, and as we started producing more research, we would actually distribute the research studies and the results published in peer-reviewed journals to some of our referral colleagues so they understand that this concept is available. Then, as we move forward, when we would have cardiovascular conference, cath conference, EP conference, we would start showing these cases and giving the history of these patients and showing the cine and the echo of how we did the implant procedure just to gain awareness. Moving from that, we've done some local educational programs and symposiums, which are general cardiology symposiums where there was a topic on appendage closure. And we started in that way, and ultimately physicians have requested us to come to their office and sometimes give noontime presentations. Sometimes my study coordinator or research colleague will go there to give a presentation. Oftentimes I've gone. So there is a process, but I would recommend starting first in an academic fashion so that you can gain credibility to the concept, because there's a substantial amount of data out there, and this will allow a physician to actually look at this in an objective fashion. Bringing up the topic of WATCHMAN is very easy to do because most physicians despise the use of warfarin. So it's not a very tricky subject to approach. Typically we give a talk, or I've given a talk, on different concepts for atrial appendage closure, and specifically different concepts of stroke reduction. And when you sit and you discuss the issues with warfarin, everyone's in agreement. There's no one that's going to stand up and say, I like warfarin. What referring doctors really want to know is the data. Is this procedure safe? And how can my patient benefit from this? And who's an appropriate candidate for this? Most of the explanation is not the procedure itself, but it's actually the data behind the procedure and the potential improvements that patients can have after they have the procedure. As of date, we have so much data. We have over 4 years of follow-up. So it can get kind of overwhelming to a referring physician if you try to lay out all the data at one time. So I tend to focus on a few factors. I tend to focus on, one, the risk of embolic stroke, the risk of hemorrhagic stroke, the risk of major bleeding, and the risk of cardiovascular and total mortality. So when I explain the procedure to the referring doc, I basically have an animation or I have a drawing, and I show them the access point that we go through the femoral vein, not the femoral artery, as most physicians believe to be the access into the heart. We explain to them it's a venous procedure. We show them how we go across the intraatrial septum, how we use ultrasound to show us where that septum is so that we can do this safely. And I also explain to them that most of these holes that we make through the septum are closed when we go back and look at this in 6 weeks' time. Once we get across, we have a special technique to identify where the appendage is, something that we do on a daily basis in the lab. And once we get into the appendage, we measure the size and shape of the appendage, and based on that size and shape, we deploy a device that will fit appropriately in the appendage. Based on the most recent results from the PREVAIL study, we expect that 95% of implant procedures will be successful, with only a few percentage points of patients that just did not have a successful implant. It's also important to explain to them that once the implant procedure is done, these patients should be anticoagulated with warfarin for 6 weeks' time. And after the 6 weeks, they'll be on dual antiplatelet therapy, and at 6 months' time, they'll be on single antiplatelet therapy.